Hello, everybody. This is Dr. Radialis from the Georgia office. So today it's going to be a little bit more informal. I'm going to talk about a few endometriosis cases that showed up in the last few weeks, and then let you guys take the floor. So today I had a beautiful lady come in, and she's had done IVF in a local clinic before. And she was a little frustrated because she's 34, her AMH is 1.6, and they just kind of gave her the average protocol for the clinic. There was no immune protocol involved. And she felt that they did not address her endometriosis, and it resulted in 2 IVFs with no successful transfers. So our discussion today was, what else can I do? And so the discussion went as follows. She had a stage 4 endometriosis that required a bowel resection in 2018. That tells me quite a bit of the amount of inflammation in her pelvis. So, you know, she transferred to our facility her last 2 embryos, and I had not met her before today, but I was somewhat following her care, or co-managing, if you want to call it that way. And she kept having this fluid in her lining. And when I talked to her, she was saying that it has been a recurrent issue even with her previous clinic. So fluid in the lining, among several things, is one, it's a kind of a weakened endometrium. So it's not being able to support the lining at the right thickness without starting to degenerate. And two, signs of inflammation and or infection. So she came in today and we had canceled her FET cycle, and then started her on triple antibiotics, even though we had not done the biopsy yet, but she just started. So today I did a robust endo scratch in the office, and I will send for pathology evaluation, make sure that if there's any endometritis, or make it an official diagnosis. And we did PRP as well. And then, so she's going to do the triple antibiotics, and I put her on Orlisa. And of course, she does want to do, she's going to transfer the embryos that she has, but she also wants to do a retrieval, which was another discussion that we had, whether to leave the embryos frozen and just go, do some priming and go through a retrieval, or just try to transfer and see what happens. So she hasn't decided quite yet, but regardless, I did put her on Orlisa for 1 month and supplements, and did the endo scratch and the PRP today. In her previous clinic, they had removed her tubes because they were scarred down from endometriosis. So that was, let's put it this way, it's not a question anymore. Among the things that we also discussed was priming. She had heard about Omnitrope. I told her that because she had such an advanced stage endometriosis, that was probably not a good idea for her because it's going to flare up her endometriosis, and we're actually trying to cool it off. I did talk to her about ACG priming, which is an indirect way of doing androgen, so like DHA testosterone priming. It's an indirect way. It's doing it higher up in the cascade of metabolic pathways in order for your body to create its own instead of just adding extra one. So we had all these discussions, and also we talked about potentially, because she had had so many failed transfers, we talked potentially about doing an ERA, even though there's conflicting evidence whether it's worth it or not. But I think that there's a small group of women that can get some additional information about that. Okay. Endometriosis is an interesting scenario. Sometimes it does not correlate with the symptoms. That was a question that I had today from another patient. Um, she has documented PCOS, but she's had recurrent miscarriages, and she did have 4 C-sections. So she was sent for an MRI evaluation, and the MRI actually showed endometriosis implants throughout her pelvis, or suspected, because endometriosis is the diagnosis of pathology, meaning somebody has to go get a biopsy and then the pathologist makes the diagnosis. But she did have I read with her the report, and but she has no pain. And so she was a little puzzled at the possible diagnosis of endometriosis, and she asked, so what should I do? And again, I had the discussion with her about laparoscopy, hysteroscopy. It would be therapeutic, but also diagnostic. She did not want to be as aggressive, so she opted for a receptiva, which is a biopsy of the uterus that will let us know if there's biological markers in the uterus that, if they're elevated, it associated with increased risk of endometriosis. Now, it's very important to understand that a positive receptiva does not indicate absolute endometriosis, because endometriosis is a diagnosis of pathology, like I was saying. All right. So in her case, she pretty much had silent endometriosis, and that could have been in conjunction with her PCOS, the reason of not being pregnant, even though she's been trying for 5 to 6 years. Everybody was thinking, oh, it's just the PCOS, but then she had all these implantation failures. And looking at her IVF cycles for a PCOS, like a pure PCOS patient, I would have expected different results. The first IVF, she was put on a low dose that eventually had to increase, and there were only 12 eggs. So that doesn't really go with endometriosis. I'm sorry, with PCOS only. And then out of the 12 eggs, there were only 3 embryos. That type of scenario, it's more of an endometriosis scenario, because endometriosis, it is toxic to the environment where the eggs are. Okay, it's toxic to the ovaries, and many times there's endometriosis on the ovary, causing local inflammation as well. So if you have endometriosis, it is it's a balance between kind of cooling off the pelvis without over suppressing the ovaries. Is a very, very thin line that we need to walk in order to get you successful eggs. I've had in the past, especially the more severe, that end up having chocolate cysts or endometriomas, which is cysts that are endometriosis in the ovary. Those type of patients, unfortunately, have a little bit of a harder time, and a lot of times end up having to use donor eggs. But I have had in the past patients that with endometriosis that successfully have been able to use their own, but it's a little harder. Okay. One of my favorite stories, and I've shared her story many times right now. It's a patient that I met. Let's see, we've been together 10 years. So she has been longer than any of my husbands with me. So we've been on this journey together for over 10 years, I think close to 12. I met her when she had just gotten married, and I met her because she was having pain. And when we did all the diagnostic testing, she actually had an endometrioma, went in, did surgery, and diagnosed her with a stage 3 endometriosis at the age of 34, 35. And she had just gotten married a year before. So suddenly getting pregnant became high in the priority list after I explained to her what the findings meant. Unfortunately, in that journey of hers, we went from minimal intervention to just oral and time intercourse to IUIs to multiple IVS. And unfortunately, even though she was making eggs, the embryos were not sticking. And there's again that question of that toxicity of the endometriosis. Even though the last laparoscopy I did on her, it was visually clear. However, there's all this inflammation that's there that is microscopic and unable to be seen by the naked eye. And I think that a lot of times we forget that endometriosis doesn't go away. It is a chronic situation that gets managed. So she finally opted, because her AMH just kept going down through the years. And at the age of 42, she opted for donor eggs. And on her first donor egg transfer, the embryo did not stick, even though it was a very good looking embryo. And then we went back on the drawing board, and I put her on Lupron for 3 months with serial PRP. And after 2 months of Lupron, brought her back still with Lupron in her system and prepared her to receive her embryos. And she ended up having triplets. So she is right now the proud mother of 3 beautiful 7-month-old babies. So like I said, endometriosis is definitely a tough path to follow. Okay. Another question that I get is, okay, what if there's signs of adenomyosis? So adenomyosis is the close cousin of endometriosis. So endometriosis are glands from inside the uterus that actually grow outside, while adenomyosis is glands from inside the uterus that grow into the muscle, but it's also an inflammatory, condition, situation, and sometimes gets overlooked quite a bit. I've seen people have signs of adenomyosis and history of difficulty getting pregnant, and because they don't have that diagnosis officially, it gets overlooked. So the treatment, it is the same. Okay, the treatment is suppressing those abnormal growth of glandular cells wherever they are, and then preparing the uterus to receive a possible baby. Okay. If any of you is out there and you are dealing with endometriosis or adenomyosis, you are free to reach out through my Facebook page, Maribel Verdiales MD, and I'll try to help you the best I can. Okay, so all right, so we have some questions. I'm having continuous cysts for 6 months. Okay. Okay, so she has multiple cysts. They put her on estrogen, and then it just got worse. And then she's planning to use Leuprolide or Lupron 2 weeks after ovulation. So low AMH with an antral follicle count of 3. Something that you might want to consider is 2 things. For example, you can partially suppress the ovaries with Provera, just progesterone only, and then maybe doing a Lupron flare, okay? Or you can definitely start the Lupron about 7 to 10 days before you expect your period. So suppression should be minimal. The thing with the Lupron, so what is a Lupron flare? Let me back off a little bit. My brain just went. Lupron, it's gonadotropin, it's GnRH, which is at the level of the hypothalamus, and it is a stimulant. All right, it makes the pituitary produce FSH and LH, right? So when you start giving it, and the hypothalamic hormones are pulsatile, growth hormone is pulsatile, it's like boop, boop, boop. But when you actually use it continuously, it functions as an antagonist. So that gap between being a stimulant and being a blocker, where you go boom and then kind of go down, that is what we call the Lupron flare. And that's why we use Lupron in low dose to provoke ovulation, because you're going to force that LH surge indirectly. Okay, so your doctor is essentially, you're going to have the Lupron flare early on, and that's why he or she wants you to do 2 weeks of that, so you fall in the area where it's suppressive. I've seen people do okay with that. It's kind of a hit and miss. A lot of times with this IVF process, it is diagnostic and therapeutic. If you're having constant cysts and they tried the estrogen and got worse, then it might be a good idea to do a little bit of suppression. More than 2 weeks of suppression, if you have low AMH, I would, I would feel a little nervous about it. So day 21, birth control pills, no. Birth control pills for 2 weeks and then Leuprolide with age of 42 and low AMH. That makes me very, very nervous. So I don't know who your doctor is. I'm sure that, they've done this before, but if you want my more detailed opinion on what you're describing, I would suggest to reach out to me. They sometimes do 10 units to start, and then they taper down to 5 units until trigger. So it depends on what they're trying to accomplish. But 21 days of birth control pills followed by Lupron makes me a little nervous. Is there receptiva biopsy does not indicate endo? Do we just assume there's no endo? No. So it depends. The receptiva could show as no endometriosis or as no indication of, right? The receptiva does not diagnose endometriosis. It just says that you are at risk of having it. If you're having symptoms, if you're having failed transfers, I would still try to get a laparoscopy to see what's happening, because with a negative receptiva, you can still have mild endo. Okay. Worst case scenario, let's say laparoscopy clear, receptiva negative, then chances are that you don't have that issue. But I have seen where, as an empiric treatment, even doing a little bit of Orlisa to cool down the pelvis does help with transfer. So there's a little bit of science and there's a little bit of art in medicine, all right, and a little bit of magic. Okay. Question 2. Instead of gonal or FSH 300 and LH 115 and Lupron 10, it's FSH 225 and menopause 75 and Ganirelix. So first of all, there's not a lot of medicine. There's very few medicines that are used in IVF. Okay, so you have a source of FSH, you have a source of LH. And you need to have some sort of suppression, right? So you don't ovulate without us wanting you to. And then there's the trigger stuff, okay? The trigger medication. The old school of thought was to just hit the older women really hard, very high doses of medication, 400, 600, and then 150, 300, just, a lot of medication to try to force the ovaries to make eggs. However, the new school of thought, after a lot of observation, is that for older women with low ovarian reserve, being gentler, actually lower and slower, works a lot better. So on somebody that's 42 with very low ovarian reserve, I recommend priming. I had this discussion with another of our ladies today, because you're coming from behind. You're kind of the underdog to some degree. So you would not go to the Olympics without training, right? So you have to prepare your body to go to the Olympics of fertility, which is IVF. So I recommend 1 to 3 months of priming. What does priming mean? Because it means different things for different people. In my book, it means we're going to clean up your diet. All right. So we're going to do more keto, okay, towards the keto side. So less carbs, definitely less junk, soda. Get off the grains, wheat, corn, soy, oats, rice. Get off the nightshades, beans, eggplant, all peppers. All right. If you're going to have carbs, let them be roots, potatoes, sweet potatoes, carrots, turnips. Okay. You can do plantains for those of you that eat plantains. You can do different roots. I'm from the Caribbean, so there's like all these roots that can be eaten. Okay. And then we're going to, depending on your scenario, do human growth hormone or HCG priming, PRP, glandular supplements, specific supplements that will enhance your outcome. And then sometimes I will even get them to ovulate regularly during that time frame. They can still have sex if their tubes are open. You never know. I mean, I've had plenty of people get pregnant past 40 just on the priming, just cleaning up stuff, doing the supplements, the PRP, and oral letrozole or Clomid, and sex at home. And then when the moment of truth comes in, then going, like I was saying, slower and lower. Okay. It works a lot better because it's about having better quality eggs, not having a lot of eggs and just bad quality embryos. Okay, so I have somebody here that had a failed FET. And she was told that there's scar tissue. So if there's any scar tissue in the uterus, laparoscopy, hysteroscopy, and then you want to make sure that you treat that uterus kindly afterwards. So one, do a balloon stenting with estrogen, PRP to help heal, hot compresses, anything to bring some blood into that uterus. So I usually do that if there's any scar tissue inside the uterus that could have provoked any failed implantation. Scar tissue outside the uterus, clean it up, is not as crucial as anything inside the uterus. Do you recommend laparoscopy for IVF? Is symptoms? Absolutely. I would do laparoscopy before IVF. Again, even if CNY is the most affordable clinic in the nation, you're still spending quite a bit of thousands of dollars doing this. If I were to do this, me as a 40+ woman, I would definitely want to improve my chances. And if there's any symptoms or any remote ideas that there could be a endometriosis issue, I would like to know so we can address it before you jump into IVF and have a crappy cycle and then go back on the drawing board. I see that so much. It breaks my heart. And I know that many of you come to us at a point where you've done everything else, or you've even done IVF somewhere else, or you feel that the clock is ticking, and you want to just rush into it. And then you don't have the results that you desire, and it's like a slap in the face. So I think the best thing is to just breathe, make sure you figure out everything that could be addressed ahead of time. And with endometriosis, the laparoscopy itself, it helps so much because we clean up the pelvis, and so it increases chances of success simply by dilution. The solution to pollution is dilution. So all the interleukins in there causing all the inflammations will be literally washed off. Okay, would CNY prescribe Orlisa instead of doing a lap? Yes. I actually did that with a patient today. the PCOS patient that I was describing, because of her history of 4 C-sections, one of them an emergency C-section, she was sent to do an MRI. And when I was discussing her MRI kind of showed that she could have endometriosis, and she opted to just treat it. She was like, I don't want to have surgery. I don't want to have the Resectiva. I just want to treat it. So absolutely. Can we combine microdose lupron and lupron stop protocol together? I don't quite understand your question. ACG priming, it's 125 units a day. So if you have a Novarel that's 5,000 units, you dilute it in 5 milliliters of sterile water, and then you inject 0.12 essentially, or 0.1, 0.2 every day. Should we be paying attention to the sperm quality as well? Because it seems every detail it's on the egg quality, or doesn't it matter? Of course it matters. And that's why we need to check on the boys. And that's why we do the semen analysis. A lot of times, just with the semen analysis and the SEMA4 or the extended genetic screening, we can kind of figure out the quality of the sperm, because if there's any parameters in the semen analysis that's not quite where we need to, then we need to start digging a little deeper. Endocrine panel on the boys, and also possible DNA fragmentation. So in terms of how much you need to wait for the after the laparoscopy to do your IVF, you can do it right away as long as they didn't really mess up with your ovaries. Depending on the severity, I sometimes will put my patients on Orlisa after laparoscopy and then do all the very robust priming prior to doing IVF. But it really depends on what was found and patient preference. We're here to work together as a team. Okay, so we're the coaches, you're the athletes. Is MRI effective in diagnosing endometriosis? Yes, usually with big enough implants, they will say they're that they're implants in the pelvis. Like today's lady, she had lesions in the ovaries and in the posterior pelvis by MRI. Does CNY aspirate cyst if cyst is found on day 2 baseline? Generally, no. I have done it on rare occasions. Honestly, I haven't seen that it helps much. Okay. All right. Well, very good. It was awesome sharing some stuff with you today. For those of you that will see the video later, thank you for also sharing your love. And may you all be very blessed. We are in the final days of 2022, and I hope that 2023 brings a lot of blessings to you and your loved ones. I will see you next Wednesday. If you want to reach me, you can just send me a message through Messenger. Please give me your phone number, and I will get one of the staff members to reach out so we can set up an official discussion of your particular case. All right, so bye-bye.